Thanks ever so much for 3 great talks. So we're just getting the speakers up onto the stage and we'll get some questions. Just as a reminder, there's a feedback form online. If you could fill it out, then you get a certificate for your CPD so you can print it off and upload it to your portfolio. So that'd be really great. Thank you. From the floor, any questions? Got one over there.
Hello, I'm Dr. Tulada. This is a question for Dr. Aziz. If a patient has positive anti-TTG and the endoscopy and biopsies on gluten diet comes back negative, would you say that's celiac disease?
Is that for me? Sorry, yes, for me. So, sorry, the question was they've got positive TTG on a... Pardon?
If anti-TTG antibodies are positive, but endoscopy and duodenal biopsies are negative,
so
what would you...
So in that scenario, you're saying that they've got positive TTG antibodies, but the histology doesn't show villus atrophy. So in those individuals, we would classify them as potential celiac disease in that situation. And what we know is that there's a bit of debate in the literature with regards to whether these patients should go gluten-free or shouldn't. But what we do know is that actually going gluten-free can lead to an improvement in symptoms. So generally, from my practice, I would suggest that they could go gluten-free in this scenario, as we know that a proportion of these patients may eventually become confirmed celiac disease later down the line. So it would be a diagnosis of what we call potential celiac disease, yes.
Will HLA-DQ help in diagnosis?
So HLA typing is mainly used for exclusion of celiac disease. So we know that about 30% of the population in general will be positive for HLA-DQ2 or DQ8. However, we know that almost exclusively, almost all patients with celiac disease will be positive for HLA-DQ2 or DQ8. So I would say in scenarios where you want to exclude celiac disease, so for example, if a patient is unwilling to reintroduce gluten, then if they have negative HLA typing, that would exclude celiac disease, but a positive test wouldn't help with regards to diagnosis. And also many centres may not actually be able to do HLA typing as well. So generally, I wouldn't do that routinely.
I think we've got another from the floor. Just whilst the microphone's going over, we have one thinking about EOE. If a patient is referred with dysphagia on the 2-week wait pathway, will they have all biopsies and will they have 6? Or is the incidence of EOE too low to warrant the biopsy?
No, the incidence of EOE is 25% of those sent. Therefore, it's absolutely warranted. They should have 6. So it's now in the BSG guideline, and it's a standard in terms of endoscopy standards that everybody with dysphagia needs to have multiple biopsies, multiple levels. So it's very clear.
And I think that's really important. And when as a GP, you're picking up that 2-week wait pathway report back, to check that not only was the gastroscopy normal, that they had the biopsies to exclude or include EOE.
Otherwise they'll get missed.
Yep. So we have one from the floor,
Yes, thank you for Dr. Rej again about the celiac disease. In the case of the lab not providing the endomysial antibody testing, or for the patients that are with low positive, so maybe 7 to 10 upper limit of normal, would you recommend testing the TTG again with a different sample?
So I think if the TTG is borderline elevated, I think a referral to actually secondary care for consideration of gastroscopy and duodenal biopsies would be the way to go in that situation.
So you wouldn't say that double TTG and no biopsy would be an approach for adults at least?
So sorry, you said repeat the TTG and...
just repeating the TTG to have a no biopsy approach.
So I think that the only situation for kind of a no biopsy approach at the moment from the evidence is really with regards to high elevated TTG titers are more than 10 times the upper limit of normal. I think otherwise we would do kind of standard practice. So if there is a positive TTG titer, I think they do need referral into secondary care for duodenal biopsies for the exclusion of celiac disease. And we do know that celiac disease is exceedingly common with a prevalence of about 1%, as we mentioned.
And I think that's a really good point. And just to follow up on that, I guess the danger there is that TTG is 7 times the upper limit of normal. You say, okay, well, what do we do if we repeat in 4 weeks, 6 weeks? If it comes back at 7 again, where are we going with that? Do we say, oh, well, at 7, it's nearly 10, let's label it as celiac disease, but actually, we could have actioned that referral into secondary care for review, for duodenal biopsies, and try to clear up that diagnosis. So, yeah. I've got one just, again, about EOE. So, do EOE patients have systemic eosinophilia on FBC? It's a good question.
It's a very good question. The simple answer is no. So
Okay.
only 5% of them have a rise in their eosinophil count, so it's not worth doing the test. And just on that subject, there's no blood test you could do because it's an IgG4 localized mucosal pathology in the esophagus. There's no IgG, IgA, or anything, or anything to detect in the blood. So there's no value in doing a blood test.
Just the biopsies.
Stephen, I'd love to talk. Can I ask you a question, and you won't take offence? We don't see the number of food boluses that you're describing. So we've just been chatting, and we've concluded that it must be that they're coming to ENT, and actually we're not engaging, and that we need to do something about this.
That is quite correct. So I mentioned that I was in Cardiff yesterday, and in their audit, they used the ENT data as well as the gastro data. And that's where they got their 300 per annum. And that's exactly the number I would estimate mathematically should be there. So you're absolutely right. Currently, your A&E department is probably sending them to ENT. ENT don't look down the esophagus. They're only interested in the airway. That's not their fault. It's their job. And so they just don't diagnose it. However, with the cooperation of ENT, we'll change the policy in A&E departments to try and get them all a gastroscopy. Thank you.
Do we have any more from the floor? How are we doing for time? We got one?
Do stable patients with celiac disease need any follow-up in secondary care once an initial diagnosis is made?
So, sorry, the question is with regards to follow-up.
Yeah.
So I think that nice guidelines would suggest that individuals with celiac disease should be offered an annual review. So that would be checking individuals' height, weight, symptoms, as well as adherence to a gluten-free diet. And I don't think that necessarily needs to be done in secondary care. However, I think there's some important things for us to highlight here. That sometimes in primary care you might think about doing celiac serology to assess how the patient's doing with ongoing symptoms. But what we do know is that individuals can have normal serology but have ongoing villus atrophy. I think from a primary care perspective, the most important thing is if a patient has ongoing persistent symptoms, then they do need to be re-referred into secondary care for evaluation in that circumstance.
Excellent. I've got no more questions on here. If there's nothing else on the floor, if you could join me in thanking our speakers, that's very kind. Thank you. Thanks, guys.